Good evening. Thank you for joining us for the Arizona chapter of the American Academy of Pediatrics panel presentation on school reentry and children's health in the time of COVID-19 for pediatric providers. I'm Dr. Jason Vargas, Arizona AAP President, Community Pediatrician in private practice in Glendale, and a father of 2 school-aged children myself, and I'll be your moderator tonight. As Arizona schools and students prepare for reentry, AzAAP's Pediatric COVID-19 Training Center has been gathering, preparing, and releasing resources to help you navigate this complex topic, address parental concerns, support schools, and deal with challenges in the community. AzAAP has contacted our congressional leaders to request they support schools so that they can adapt and make necessary changes and accommodations so that students, teachers, and staff feel safe. AzAAP has released a position statement. In lieu of reading the whole thing here now, you can find that on our website. I'll summarize it for you. The Arizona AAP believes that the best place for children to learn and to address their complex needs is to be physically in school. And conversations and strategies surrounding this issue should start there. We all know that the closure of school has many educational, developmental, behavioral, nutritional, and social effects. These decisions regarding school openings should be guided by science and be tailored for the specific characteristic and needs of each community. To achieve the balance of fulfilling the many complex needs of children with controlling the spread of COVID-19, a collaborative approach, including educators, public health officials, pediatricians, mental health professionals, and parents should be taken. This panel presentation is just one more way to help members to get the information they need to participate in this collaboration. This panel discussion is brought to you by the Arizona Pediatric COVID-19 Training Center. We urge our members to visit the azaap.org website. There you can also find links to the new podcast, ID Talk, answering your questions about COVID-19 by Dr. Sean Elliott. You can also find the Back to the Office campaign materials, where you can print them out yourself. There you can also find the new Arizona Provider Toolkit, Caring for Children During the COVID-19 Pandemic, with robust resources for providers to work alongside school systems, provide guidance and means to keep students, teachers, school administrators, staff, and families healthy, safe, and secure. We encourage you to review the toolkit if you haven't done so already. So without further ado, we are very lucky to have a group of esteemed panel presenters to answer questions today. In the interest of time, their full bios can be assessed in the handout section of the webinar this evening. First, we have an infectious disease expert, Dr. Sean Elliott from the University of Arizona College of Medicine. We have a sports medicine expert, Dr. Kristina Wilson from Phoenix Children's Hospital and the chair of the Sports Medicine Advisory Committee for the AIA. We have a public health expert in the director of the Arizona Department of Health Services, Dr. Cara Christ, an education expert, Arizona School Administrators Executive Director, Mark Joraanstad. So before we begin, thank you all for joining us here today. Just some housekeeping notes. Only panelists can be seen and heard during this evening's session, and all attendees will remain muted. We will begin with some questions submitted by members in advance. If attendees have additional questions for the panelists that we're not addressing here, they can submit it in their question box in the navigation bar, and hopefully we can get to it at the end. If there's time, we will get those, but if not, we will make sure that we try to get those on future podcasts or perhaps another panel in the future, okay? So let's get started. First questions. So this is for all panelists, but pediatricians know children learn best when they're in school. However, returning to school in person, we know, must be safe. In your opinion, is it safe to send all children back to school in Arizona now? Dr. Elliott, would you like to begin?
Hot seat 101. Hey, everyone. Thanks for inviting me. So the short answer is today, my answer is no. That there are a fair number of achievables that we have yet to achieve in Arizona before I think we could consider a safe return to school. And also, I want to be very clear that a one-size-fits-all approach is not appropriate. Perhaps to help frame our discussion and the response, I wanted to briefly summarize the evidence which is out there, since we are not alone in asking this question. Many have asked this in other countries, other parts of this country before us. So first and foremost, what about COVID-19 in kids? In general, Kids are far more likely to be asymptomatic or mildly symptomatic, with the obvious rare exception of those rare children who have the multi-system inflammatory syndrome in children, the MISCI. And that has to be a real concern that we need to consider in our approach. But in general, kids do better. Also, kids, and this is emerging evidence, appear to be less contagious at younger ages. There's very recent data, actually a very well done study out of South Korea, looking at secondary attack rates in families at different age groups. And the 0 to 9 through 9-year-old age group of children only had a 5% risk of precipitating secondary cases in their families, versus the 10 to 19-year-old age group, which had a 18 or 19% risk. That was even higher than adults in the 30 to 49 group. So that sort of breaks this down into the K through 5th grade and the middle school and high school age groups. Very clear delineation, knowing, of course, that there's a spectrum of risk as we get into the older ages. But younger children seem to be less likely to transmit disease to adults. The real risk, of course, is adult to adults, but much less likely kids to adults and kids to other kids. In the high school group, though, that risk is still somewhat significant. So that's sort of the attack rate. That's the risk of these kids. But in general, this is a milder illness and a milder attack rate for younger kids. What about those parts of the world that have already encountered a reopening? Who did it successfully? Who did not? Denmark and Norway have both published their results. They had a successful school reopening. And the way they did it was to wait until community attack rates were low. In fact, those countries waited until percentage positive in their countries were well below 5% positives. And they had a clear, transparent, phased approach to opening up their classrooms with social distancing, with mask wearing where appropriate, with hand hygiene campaigns. And they had a very effective in-place protocol for doing contact tracing should a child have turned positive in the classroom. And that required rapid turnaround for testing. So these are clear achievables, which we can achieve. We just have to be able to get the resources in place to do that. Israel had an unsuccessful reentry. And initially, they thought their numbers were low, but Israel experienced a surge due to other community issues. And they relaxed their social distancing and classroom size restrictions way too early. So early in the reopening, classes went back to very densely crowded students, and they had a huge surge of secondary cases in kids in the classrooms. So that's sort of proof of how not to do it. And it's not to point fingers at Israel, they just had their experience. So I think if we can achieve a phased approach, meaning a gradual starting with K through 5th grade, when it is safe, and we have our transparent protocols in place and the ability to do contact tracing, then I think it's reasonable. For high school and children with special needs, those populations may need to wait just a little bit later until we can confirm lower community spread and that it's safer. So.
Good. Dr. Christ, care to comment?
No, I would agree with that answer, and I apologize for any technical issues. My computer keeps freezing. So if you see me stop, that's why. But we agree, we are looking at all different types of metrics as we are developing benchmarks in partnership with the Department of Education to really show what our cases are doing, what community transmission looks like, and where our hospital capacity is. So all of that is going to play a role for when it's safe for children to return. I think one of the really important pieces is that even if we get down below like a 5% and minimal community transmission, there still needs to be that flexibility for kiddos that have underlying health conditions or may have individuals at their own home that may be at high risk. So I think we're going to need to have this flexibility and a virtual hybrid learning for quite a while into the future.
Correct. Well, I mean, there's a lot of things to consider. This, I don't even know if we even have the capability of getting all that information right now, but let's talk about some of the things that we would be able to do in the schools that would, that the sort of things that should be present in school before coming in. A lot of parents will come into my office and ask me, Dr. Vargas, what are the things we should be looking for at the school so that we know that it's safe? What are the sort of things that can be done in the school to mitigate some of the risks? Dr. Elliott?
Oh, all right. Well, so I think one important question which has been asked is what is the benefit of doing symptom questions or symptom tracing or even screening by the nasopharyngeal swab every child on entry? And that specific, I think, is not going to be productive. Remember that most kids are going to be mildly or completely asymptomatically infected. So symptom screening is not going to help. So too with adults, screening our teachers, our support staff. There's a 40% estimate of asymptomatic infection in the community. So that's not going to be useful. Similarly, swabbing everybody's noses, of course, there are false negatives. What's the power of a negative result? Not much. And you have to really justify the discomfort and the cost. So I think instead, having the community indices, as Dr. Christ was sharing, and having trends of decreasing attack is going to be the key thing here. But then also setting up the classroom so that we can have social distancing. So 6 feet separation between the desks or the study areas, if you will, seems to be quite reasonable. Even having campaigns for hand hygiene, having stations available for that. Mask wearing would be ideal, but of course, I think trying to get a kindergartner to wear a mask reliably and effectively is a different thing than asking a 13-year-old. So that doesn't mean we shouldn't try, but I think all those can be interventions that we can at least attempt.
Mark, what do you think, what are the schools trying to do what other things are looking at to institute some of these changes with regards to the social distancing, hand washing protocols that Dr. Elliott talked about?
Well, and I would agree with a lot of what Dr. Elliott said, and really schools and districts are looking at multiple strategies, but we would especially agree with what he just said about temperature taking every day. We had a phone conference with about 118 superintendents last Friday with the Centers for Disease Control, just for Arizona superintendents. They recommended exactly what he said, that taking everyone's temperature every day is an exercise in theater, really. It's not an exercise that's very helpful. But to go with the social distancing, establishing cohorts so that you've got a group of kids who stay together all day long ideally with a limited number of adults, or in an elementary school, the same teacher. So there's limited exposure of those kids. Then if someone does test positive, you can do contact tracing very easily because you know that student has had a limited exposure to a certain number of other students. They eat lunch together, they stay together. That kind of cohorting is very important. A public relations campaign so that you know as a parent, if you're looking at that school, they have a culture of safety that they're really building. They're building it in the signage, they're building it in the employee training, they're building it in the student communication, they're building it in the communication with families, on their websites, in other ways, so that you know they're really taking this seriously. You're seeing the masks. They're building a culture of students wearing masks, but they're also thinking about this, that they're giving the students a break from masking occasionally when they get out on the playground and they can maintain appropriate social distancing. Then they can take the masks off, so that, kids will probably wear the masks if you give them a little break occasionally when they're outside and they're safe distancing, then let them take the mask off for a little bit. Encouraging parents to do home symptom screening every day before sending the kids to school. So if there's a question of a fever, that's taken care of before the child gets to school. Is the school prepared? Has the district and the school prepared procedures for what to do when someone expresses symptoms? All of these things parents need to look at, and schools are planning. Just to be honest, just a multiple use of strategies and practices, almost overwhelming, but we've got trained leaders. We've been training all summer, so sometimes when they stop and think, it seems overwhelming, and that's when you chunk it out. You do one thing at a time. And if I can say one more thing, they also have a point of contact for all COVID-related questions for the community. So one message coming out and not. Okay, I'll stop.
Oh, excellent. I think that's well said. I think that's very important. Source of information sometimes, pieces coming from here and pieces coming from there. Pick and choose. Sometimes the overall message is not anything that is coherent, right? With regard to masks, obviously not a source of contention at all, but should schools require that all students and staff wear masks?
Well, I'm going to say yes, and are there some exceptions? Yes, there could be some medical exceptions for some students who wear masks. With the younger kids, you're certainly going to try it. It's keeping kindergartners with masks on all day, that's going to be challenging. But it's amazing. I was an elementary principal for many years. I saw our kindergarten teachers be so creative in how they establish routines to get some of those basic things done every day. They had routines for every little thing, and my guess is that kindergarten teachers and first grade teachers will be developing routines around them wearing masks as well. Now that's going to be improved a little bit if school starts virtually and they aren't able to start with the kids in the room. The establishing of those routines will take a little longer, but my guess is that there'll be a way of establishing that as well. And similarly with the social distancing, that's going to be very challenging because everybody's natural intention in the early grades throughout actually is to love the kids, and that involves the very opposite of social distancing.
Right. Well, my experience in the office, Kristina, I don't know if Dr. Wilson, I don't know if you want to chime in with this, but is that there seems to be an age, probably first grade to about fifth grade, where the kids actually, they're the ones that have the best mask wearing, right? They understand very simply that this is what I'm supposed to do, so I'll do it. Obviously, the preschoolers and things is very, very difficult. But once you get into the middle school and high schoolers, it becomes a little bit more of a challenge. But we probably know that this is probably the population that probably where we need to have more people wearing masks. Would you agree?
I would definitely agree. And I would say that a couple of things, definitely I think the kids who are like in the elementary school age, that first grade to fifth grade, that actually have the least disease prevalence, as Dr. Elliott pointed out, are really the kids who are great about wearing it and still have a sense of community. I mean, that's what we're teaching them. We're teaching them how to interact with each other, and that social interaction is huge for them. And so they still have that sense of community and they want to do things to help other people. And it's also, I think, a great way that parents can help them, and you can encourage the parents to teach them about how they can have control over the things that they can't control, and just to help with some of the anxiety they have about going back to school, is that they're doing this because this helps to not get other people sick or get their teachers sick. And I think it really empowers the kids. Absolutely. Obviously, I deal with a huge adolescent population in my clinic. They're definitely influenced by their parents' thoughts and beliefs. And I think that's where we're going to struggle a lot with some of those kids, because obviously the families who are less likely to promote mask wearing and social distancing are probably the ones who are going to be the first to get their kids back into school. And I think that's a concern for those of us that obviously are on the opposite end of the spectrum, where we live in this world 24 hours a day and obviously see the benefits of getting our kids back in school, but want them in school where they're going to have everyone doing what is the right thing to do, which is wearing their mask and socially distancing and maintaining that healthy environment. And so I think that's one of the biggest challenges in the high school population, is the enforcement of the healthy behaviors that we're trying to encourage them to do.
All right. So let's say we did everything right. Everything's perfect. We have all our systems in place and everything is working well. What, Mark, can you tell us, are schools thinking about doing if a student or a staff member starts developing symptoms of COVID-19 or a cold or test positive for that matter?
And And I'm sorry to say it's not going to be if, but given we have 1.1 million students, it's going to be when. So we're planning for it. And one of the things, of course, that's very important we're talking with schools about is to have an isolation room, an isolation area. So if someone shows up at school with clear symptoms, or during the day a staff member or a student develops clear symptoms, of course, you immediately report it to you have that designated point of contact. You have we're trying not to say COVID person, because who wants to be called a COVID person, but you report that, and you remember that HIPAA is involved, so you maintain confidentiality, but then that person, you separate that employee or that student to the isolation room. We're trying not to call it the QR, the quarantine room, because it's by symptoms only, you don't presume, but to the isolation room, and you contact the parent, or you close that off. If you have to transport someone home, or whether employee or student, or to a medical facility, you do so. You try to close off, and this is really challenging, you try to close off areas, or an area, if your cohorting is good, where that person was for 24 hours. And again, given our schools don't have lots of empty rooms, this is really challenging, but you try to close off the area for 24 hours. Ideally, you would wait 24 hours before going in and doing a thorough cleaning and disinfecting. But reality says sometimes that's not possible. Then you determine who's been exposed within 6 feet or close contact for more than 15 minutes. Then you begin notifications if it's a classroom. And we've really struggled with this because the ground has been shifting. You know, what we were hearing in April and May, we're hearing a little differently in June and July, you know, but certainly if it's a student in a classroom, if it's symptomatic, you probably notify parents, but if it's a positive test as well, you notify parents. And you end up, you know, probably telling people you're all staying home. If you've been exposed, you're all staying home for 10 to 14 days. That's not going to be received well. Just making sure you notify everyone sometimes is not as easy as you think as well. And then people have to get tested. They have to have a positive, what we would think of as a positive outcome, a negative test to be returned. If it's just, what should I say? I'm not an expert. I shouldn't be telling you this. We've got people here who know. What we're trying to say then, though, if the symptoms were not related to COVID, but to something else, generally you still wait a few days before bringing that student back, because we're all saying basically an abundance of caution is one of the phrases we're using. Err on the side of caution, and a whole bunch of people don't get sick. That's far better to annoy some people and you don't get spread, rather than you give in to annoyed people and then you have an outbreak. Cohorting is so important here. This is where the importance of cohorting comes in, because then you can contact trace, and maybe you just have to close a classroom. You don't have to close, you've got a student who's been exposed to 200 people. Now you're talking, and those 200 people have been, now you're closing the building. So that's why cohorting, where possible, very difficult, really difficult in a high school, much less difficult in a K-6 elementary school. Anyway, we've been working on that in great detail, still working on it. It's ongoing. The Arizona Risk Retention Trust, the insurer of almost all the districts, has provided great detail on all those things, as well as the CDC guidelines. So that's where our guidance is coming from.
Well, our school nurses and school health services now are becoming frontline providers, right? At any point, they're actually being exposed to this. So what are we doing to help mitigate the risk of them? Are they going to have proper PPE? Are they going to be being tested regularly?
The PPE, yes, the testing, that's something a lot of districts are not, districts are not, to my knowledge, I'm not aware of any districts that are testing on their own. Some of them are referring people out to be tested. There's been frustration over the delay in getting the results of the testing. So that's one of the things that is still being worked on, is the whole issue of testing. The CDC in last Friday's webinar that I referred to advised districts not to get involved in testing, which most of us had decided that already, but to try to establish a relationship with a lab or with someone who you can send employees to regularly, and you develop that communication, and so you get that established, which districts are trying to do. For some rural Arizona, that's more challenging than in the metropolitan areas where you have a multitude of sources available. That's an area we're still working on.
Well, I'm going to pivot back to testing, but we have a question from one of our listeners here that has a question about masks and mask hygiene. So if most people are going to be wearing masks at school, what is proper hygiene for not becoming contaminated with a mask? Dr. Elliott?
Right. So of course, there's the official protocol like donning and doffing PPE. The challenge with the mask, of course, is that there are two hot surfaces, if you will, that the inside surface facing the wearer's nose and mouth is where the majority of the benefit of the mask comes. That's where we're exhaling or expiring potentially infectious droplets. So taking off the mask, trying to avoid touching the inside of the mask is probably the most appropriate. But there's now some evidence showing that the masks have some of a protective factor as well. Estimates as high as 40% for the 3-layer cloth masks and 60% for these, the surgical loop masks, in protecting the wearer from acquiring infectious droplets. So if that's the case, then the external surface is hot as well. So proper hygiene, and again, this can be part of our outreach to educate the students and our staff, is to handle the mask by the far corner of the mask or by the loop itself, if at all possible, donning and then doffing. So it's not going to be perfect, of course. Probably the most important approach, though, is after handling the mask, either putting it on or taking it off, is to do the next step, the hand hygiene, and to have the alcohol-based hand cleaners, which we can have, throughout the school system, or if we're reluctant to have that for certain age groups, to have the soap and water. That's probably the most easily accomplishable way to decontaminate the hands.
It strikes me then there's a lot of training that needs to be done to the students. Some of this probably is already a little intuitive that we've been teaching them, but it probably lends to the online format for a little while to have a little in-services with the kids before actually going back to school, right? Sure. So continue with you, Dr. Elliott, another question. And this leads into another question that I have. So how significant should someone's symptoms be before they need to notify contacts from the school? Or is just someone in the house is positive?
No, boy, that's the million-dollar question, of course. Like how low a bar do we set? How low a threshold do we set? And I think we have to be quite conservative in our approach. And so any symptom, certainly fever, that's a no-brainer. Like child develops even a low-grade fever, that they stop, send for evaluation. Central to that is going to be the ability to have a rapid turnaround testing construct to key on what Mark was talking about. None of this is going to work if we cannot do our contact investigations rapidly. And if we can, then we have the luxury of investigating even minor symptoms quite quickly. In kids, remember, development of symptoms is probably a majorly infected kid. And so low-grade fevers, malaise, any respiratory symptom, that's a stop and hit red flag right there.
Yeah, I know at least in my office that testing kids on a regular basis is just not a practical thing. If they're thinking that the parents have it and the child might have some small amount of symptoms, then I presume that that's a pretty good idea that you have it and just to watch for secondary respiratory symptoms. But as we matriculate back physically into schools, we're going to have, as you say, a construct for checking a lot of these kids. So,
we cast a
right.
wide net, so we try and miss as few children as possible. Possible contacts in the family, yes, that counts as an indication to do screening, yes.
Right. So, Dr. Christ, I know that at least in our office, sometimes when we're checking people, it's taken often sometimes more than a week, 2 weeks to get the results back. Obviously, this is not going to be a practical thing when we're looking for the information to get back to school. So can you tell us more about efforts to increase the testing capacity and turnaround time?
I can address that one if that works.
Yeah, thanks.
We in Arizona are working with our commercial laboratories. So we do know that Sonora Quest, who provides about 75 to 80% of the testing in Arizona, there were several issues, both with national supply chain and with difficulty getting the requirements for their platform. They recently acquired a new platform that is not dependent on US reagents, and that actually is developed in Europe and should not be now are able to process more tests than they are receiving per day. So the turnaround times should be rapidly improving.
Okay, excellent. So obviously this is a moving target, and we're all trying to move as fast as we can with this. So we appreciate all those efforts. So I think, when we go to school, there's the obvious education part of it, but having two children myself who both play sports, there's a lot of other things that happen at school that make the school experience so rich for them. So Dr. Wilson, so what should pediatricians be telling parents about activities such as athletics, marching band, or chorus in school?
Yeah, I think one of the biggest things, and what I've really encouraged a lot of my parents, obviously this is a daily discussion with me multiple times a day, is to really encourage parents to be asking their organizations, because I mean, not only do our kids play sports in school, but Arizona is one of the #1 states where kids play sports outside of school and actually play more club sports than they do in school sports. And so obviously there's no governance over sort of extracurricular club sports, and this has always been a problem, but now that we're in a pandemic, it's a bigger problem. From a school standpoint, we've got, the Arizona Interscholastic Association that gives guidance and recommendations. All the schools have athletic directors. About half of our schools have athletic trainers that are there. So there's actually like an on-site medical professional and qualified medical professional to kind of help navigate this process. But what I've encouraged parents to do, even at the school setting, is to really ask of their coaches and ask of the administrators of their club sports what they're doing to minimize the risk that their child is going to get sick or their child is going to potentially bring the illness home into their family and to their home. And so most of our guidance is really based on the AAP's return to sport document, as well as the CDC document on return to sports, as well as guidance from the National Federation of High School Sports, which actually governs all of our AIA sanctioned events. And there's really 4 things that they can look at. So one of the things, and the CDC is very clear on these things. The first is just promoting behaviors that reduce the spread of illness. That's what we've talked about even just in the school environment, making sure that schools are, that they're, wearing masks during times that they're not exercising at a moderate to vigorous physical activity. So we asked, is there times that it's okay for kids to take masks off? Well, absolutely. Especially, when we have kids potentially going outside when it's still like 100 degrees. But making sure that, if they're running and exercising at a moderate to vigorous physical activity level, they don't need to wear their mask as long as they're staying 6 feet apart. Making sure that there are clear sort of physical barriers that can be identified in the area that they're participating in. And so if you have, Mark had discussed, if we're cohorting the kids, making sure that if you have more than one class out on the, the playground or the field area, that they're all separated so that the cohort of kids is always together, is sort of together, and the other groups are not. Then maintaining healthy environments, which are making sure that all the athletes are not sharing any objects. So they have their own water bottle, they have their own towels, making sure that they have their own equipment and safety equipment that they need. And so for some of the schools, this may be an expense, or for even some of the clubs. Because oftentimes there has been shared equipment, and they need to make sure, you think about catcher's gear in the spring. Obviously we're in the fall, but this may still be going on in the spring. And then avoiding communal spaces. So we've recommended actually to close locker rooms, and to, the kids can get dressed, either if they're, right now over the summer, they've been getting dressed at home and doing that. And so navigating those ways, or if they do have to change, making sure that not all of the kids are all in the bathroom at the same time changing, or in the locker room, and having staggered start times, and having less kids, and those kids are cohorted even with their sport, smaller groups, and those groups come together and leave together. To practice outdoors when possible. Obviously in Arizona, this is a huge problem. The heat too. It's not just a pandemic. It's also like 111 degrees outside right now, 119. So clearly, right, exactly. So heat stroke. This is why we address the heat acclimatization part of things in our return to the sport document as well, because it's a real issue here. And then practicing social distancing, like we mentioned, with using those physical barriers. Healthy operations. Doing daily symptom checklists, just like we're asking the parents to do of the kids going to school, making sure the kids do. The real fight we have in athletics is, we train kids mentally to be tough and to push through things. And so I equate this no differently to sort of, I think even us as physicians and providers, I've really had to take a step back and be like, you know what, if I'm sick and I need to stay home and not put everyone else at risk, where many of us were trained, I'm not that sick, I should still be able to go to work. And so it's a complete mind shift for these athletes and even the coaches, that if they're sick, even with the minor, they've got diarrhea, or they, threw up once last night or whatever, to make sure that we err on that side of caution, and you just stay home and see what happens. And if nothing else occurs, okay, and you're fine and you get checked out, then you can kind of go back. But making sure that they're doing those symptom checklists, and if they have, symptoms, that they do stay home. Also, cohorting, as we mentioned, with other things, staggered arrivals, as I mentioned previously, and then really minimizing the number of people present. So, we all know the helicopter parents that exist in sports, particularly, some of our sort of aesthetic sports like gymnastics, ice skating, I think of some, and really, making policies where there's no spectators allowed at practice. They don't need to be there. That's just more people in the building that don't need to be there. And then limiting sidelines even to essential personnel only. So this is, challenging. And one of the things that the IAA has done, we've also released modifications to fall sports, and really talked about increasing the space that they can. So normally on the sideline, particularly of football, they're only allowed to be in a box between the 20-yard lines on either side of the field. And so we've extended that to being 10 into the 10 yards. Coaches still have to stay within the 20, but basically the athletes will be within 10 if we get to that point of being able to go back to football. I've encouraged parents to sort of be advocates for their kids and their families, and to really ask those questions and see what they're doing, and make sure that they're taking those precautions to make sure that their families are safe. And on the flip side, we do a lot of coach education and training for all of our AIA coaches for each season. And I've done the same thing to them and encourage them to actually educate the parents and the families to know that these are the precautions that we're taking to try to minimize that risk. Obviously, we're not going to eliminate the risk, and we're still potentially going to see increased cases as we start to do more things with each other. But that these are the things we're doing to try to minimize all those risks.
Okay. Mark, so I've had some families come in and give me actually plans of when they're starting football. And it's a little bit surprising to me that they already have those dates. I'm sure it's tentative, but what's going on with school administrations with regards to planning sports and restarting those electives, extracurriculars?
Well, it's one of the things you mentioned is challenging, because some parents have come in and said, here's when we're starting practice. And some of this is, to be frank, completely unsanctioned by school districts and schools, because they've said, no, we're not having these workouts. They're not sanctioned. So then parents have said, I guess we will start the workouts. And And of course, without some of the protocols that the AIA, the Arizona Interscholastic Association, has put in place. I think Dr. Wilson really laid things out very specifically. One of the big sports that takes place in the fall, football, now there's a proposal now that AIA is looking at this week that would perhaps start the football games October 2nd and would be much more modified season of probably 8 games. Now in northern Arizona, a lot of the 3A smaller schools, they've canceled the season because especially schools that have Native American populations where they've been hard hit, many of those 3A schools have just canceled the season completely. They're trying to do some intramural things, but they just have gone away from it. I would mention a couple other extracurricular activities, though, that have really been affected by this non-athletics. Things like band, for example, chorus. Parents need to really emphasize if their children are in, and because music is so important to some students. But if they're playing in the band, they make sure that they have their own instrument, that they don't share that instrument, that they don't share the mouthpiece. I mean, if you've had kids in band, or if you played in band yourself, you know that in a different era, we were not practicing what we need to be practicing now, and that social distancing needs to be maintained. In chorus as well, we know that talking in a pandemic era is dangerous. Singing with cloth coverings on the face is probably not the kind of practice you expect in chorus, but just the expelling of air that you do when singing. I don't know how, some districts have not come to grips yet with how to do that. There's been virtual choruses. You might have seen some of those when you can do that safely virtually, but if you come back into school, stay away from the opera singer because they're expelling a lot of droplets. So we're working on how that could happen once we return from virtual thing. I would add one other thing as well. You want to make sure the culture of the school in regard to these events is solid. There are some questions you could just ask, and Dr. Wilson did a good job when she said talk to the coaches and ask them, who's the contact person for COVID-related activities? Can I see your practice log where you're checking in every day with every student and you questioned every student before practice about, how are you feeling? Do you have a fever? Do you have this or that? Just like when you go to the doctor's office, they question you. If they give you that puzzled look like, what are you talking about? That's not a good sign. There's not that culture in place. If they rattle off something and they call a person over who's got a big notebook wherever, then it's looking better. But there's certain indicators and signage again, other things like that really indicate this school is paying attention to all the little details. It's not just a nice, pretty display on the website. When you're at the school, are you seeing all the little details in place? So that's the guidance that I would offer on that.
Thanks. We're also getting some more questions from a lot of questions about positivity or when a child could be positive at school. So Dr. Christ, if a child has a fever or respiratory symptoms, and from about October through about March, this is what we see in our office, right? But let's just say a child has fever, respiratory symptoms. It's not like Mark said, if it's going to happen, is when it's going to happen. What's the guidance for returning to school? Negative COVID test plus fever-free for 72 hours?
So it could be a negative COVID test plus fever-free without the use of a medication for about 72 hours if you have that negative COVID test. If you don't have a negative COVID test and they were symptomatic, what we recommend is 10 days from the date that they started having symptoms, plus 24 hours after the resolution of the fever without a medication, the longer of whatever those two are.
Okay. Well, let's just say this is for you, Dr. Wilson. Let's say an athlete is positive for a test. Are these the same sort of, guidelines that were given to return back to sports?
So yes and no. So it's a little bit different because obviously it's a respiratory illness, and then we also have a deconditioning period that we've had them out of sports and athletics. And so we will actually, the AIA will, we're in the process, actually I have a meeting tomorrow morning, but we are in the process of actually kind of drafting an addition, an addendum basically to our return to play guidelines that will address positive athletes and how we recommend that they should be returned back to athletics. With that will also be a return to play form, and how we're really recommending that this is managed is very similar to how we manage concussion and return to play after concussion or head injury. And so what we've actually looked at is really 14 days past symptoms when they first appeared. And if they have, and then basically a 72-hour period of no fever and reducing symptoms like such as cough, shortness of breath, and those things. If they had, and then also we recommended because of the cardiac implications that can happen, obviously there is no data really in the young middle school and really actually even in high school athletes from a cardiac standpoint. There is a little bit in the collegiate athletes because there are a fair number of them who have gotten sick enough that have been required hospitalization. And so we are still recommending that the American Heart Association cardiac screening questions are asked of those athletes. If any of them are positive, then if the athletic trainer is sort of who's been managing their return to play, much like they are with concussion, they will actually be referred back to their primary care physician if they have not been involved up to that point. And those include, and if there's positivity to chest pain or tightness in their chest with exercise, unexplained syncope or near syncope, unexplained excessive shortness of breath or fatigue with exertion, any new palpitations that they're complaining about, or a heart murmur that's noticed on exam, which obviously would be in the office. If there is positivity to any of those, then there is a recommendation for additional workup, and whether the primary care physician feels comfortable doing that in their office. Some of those have included things like chest x-ray, spirometry, PFTs, and then potentially even cardiology consult, depending on the severity of those symptoms. If an athlete's been hospitalized, then those that screening is also at play there. And then the other thing is, and so basically, if they don't have any, if they didn't have any symptoms, but they had a positive test because like a family member or someone else in the home like tested positive, and then they got tested and they were tested, but then didn't have any symptoms, we're still actually recommending a 14-day period that they will not be released back to athletics. And then even after that, still following a return to play protocol. A return to play protocol is a gradual return to exercise and activity, really following sort of exertion, resting heart rate and those things. And it really goes over about a week-long period. And so they're looking at about 3 weeks after a positive test before they would be released back to full participation. If they had severe COVID symptoms, which obviously, fortunately, we don't see usually in the pediatric population, but if there is a child who does, then the AAP return to sport document, which we will probably agree with, is a 3 to 6 month return with cardiology following them as well. Mm-hmm. And because at that point, we're assuming that there could potentially be myocarditis or some other issue that would obviously preclude them participating in sports. And then also if they didn't have symptoms, and the reason that even the kids that don't have symptoms, we're requiring them to go through the return to play the same way, is because sometimes we found that, especially in the pediatric population, some of those kids don't really know they have symptoms until they start to exert themselves, because they just maybe had a little bit of malaise, didn't do much at home, didn't think much of it. As soon as they start exercising or exerting themselves, all of a sudden they're short of breath and having symptoms and those things. And so making sure that we obviously don't let them go back into full participation when they're still having that respiratory distress and other things.
Good information. We have a lot of questions about chronic medical issues and the risk for COVID-19, but first, before we go to that, a follow-up question, and I think it's appropriate if there's ever a time to clarify the definition of this, especially at the schools. We talk a lot about if you have fever. What is a fever? So I think, in the medical community, right, we'd all say 100.4 or 38 degrees Celsius. But I can't tell you how many times we see somebody with 99.8 because it was almost 100, which is a fever. And, at that point, we're getting pretty far from a fever. And I can understand that people may be a little bit concerned. They don't want to have a febrile child at school, but also are these things that are being looked at the school systems or in medically in general?
Well,
Dr.
I'll
Christ?
start with that one. I'll start with that.
Dr. Elliott, okay.
Yeah, it'd be great to have an absolute answer, of course, but science and nature abhors absolutism. So I think a 99.8, if it doesn't come down, if it's persistent, that's something we need to view with some degree of caution. Yes, the 100.4 is still the valid definition for COVID, but again, keeping in mind that most of our kids who may be infected are going to be asymptomatic. Any symptom outside normal at least needs to be thought about, and I would propose a case-by-case evaluation rather than having a blanket statement. One size fits all, to me, is a good way to miss some pretty dangerous situations.
Good point. You'd agree, Dr. Christ?
Yes, I would agree, especially given the high rate of asymptomatic cases that we are seeing in Arizona. It has to be on a case-by-case basis.
Okay. Well, when thinking about when parents will ask me, should their child go back to school or not, they often are referencing their past medical history. And just intuitively, if you're using a flu-based model, you're thinking to yourself, well, if you have chronic pulmonary disease, et cetera, that maybe you'd be at higher risk. I'm not sure I've seen any evidence that that's exactly the case. Obviously, any respiratory illness, they could be predisposed. But what kind of chronic medical issues or kids with chronic medical issues should we consider to be something that would keep you outside of school in this setting, Dr. Elliott?
Yeah, I think the easy no-brainer answer is any child with an immunodeficiency or significant immunosuppression. And here I'm not talking about the child with asthma on inhaled steroids, but somebody who's on a daily dose of some immunosuppressive medication. Those are easy, and we would not want to put them into harm's way. If we look at it from the other direction, and every other week I'm on in-hospital service, the children that I'm seeing being admitted with COVID-19 positivity, A, are not that sick, with the rare exceptions who have severe disease, and B, rarely have underlying comorbidities. And so an avoidance based on prior history of severe asthma or chronic renal disease or something like that does not seem to be protecting children from hospitalization. So I guess sort of the 3,000-foot view is case by case, but simply having underlying medical disorder or comorbidities, unlike in the adult patient population, needs not be a hard stop about sending that child to school.
Okay. Well, we also have some questions with regards to the type of school openings that we would have in light of the evidence that Dr. Elliott talked about at the beginning from that study in South Korea about 10 and up being being at least as good as an adult of spreading illness and not so much for less than 10. In light of that, how do we apply that to our plans for school opening, Dr. Christ?
So I think, again, that's where that flexibility really comes into play. So what we're going to be doing is developing benchmarks when we think it shows that there is decreased community spread and decreased risk to our healthcare system and to cases in general, decreasing cases in general. But we're also going to leave that to our local public health departments to work with the schools, because they're going to know specific circumstances that are going on in that community that may play a role in some of those metrics. And really working with those schools, that do they have the ability to bring back part of that population? Do they not have that ability? Do they have a high number of kids that need someplace safe to go? So it's really going to be probably, again, on that case-by-case basis, looking at the school, its population, the community around it, and what's going on in that community. Right.
So I guess that answers the follow-up question. Some listeners were wondering whether or not this August 17th date is still to reopen, in state's guidance, but I guess it's a case-by-case basis.
So we're hoping to have those benchmarks released along with the metrics by county by the end of this week, so that people can start looking at it. Looking at one of the indicator for community transmission being that person positivity. You know, right now the state's still relatively high. We still have widespread transmission in most of our communities. So we would work with our local health departments, but probably in school is still a couple weeks off.
Okay. Well, we have a lot of questions about therapeutics and what the status of them are at this point. So Dr. Elliott, what can you clarify the status of therapeutics for mild to moderate COVID-19 currently?
Right. So again, the options with true proven efficacy against the virus and against the disease caused by the virus are still somewhat small. The primary antiviral drug, which is benefit, is remdesivir. It is specifically addressing the virus's ability to bind and then to open up and translate its genome. There is clear benefit shown for those patients. The sicker the patient, the better the benefit. And so we're saying mild to moderate. In kids, that may simply be a child with underlying asthma who comes in with wheezing and requiring some oxygen and bronchodilator development or delivery. So the remdesivir may not be so indicated for that patient versus the one who comes in on high flow nasocannula oxygen or circulating the vent. It almost requires intubation. There's definite benefit for remdesivir. And most hospitals, certainly the one I work at, have protocols already in place to guide who and who does not deserve treatment with that particular medication. Far more, I think, pertinent as a low-cost and easily available intervention is the steroid intervention. Initial studies with dexamethasone quite supportive. The major benefit, again, shown with those patients, children and adults, who had the most severe disease in terms of days on ventilator, days in hospital, and even recovery from their illness. But there is even some benefit for those with the more moderate illnesses. Very interestingly, and I was thrilled to see this, a study has just come out looking at the impact of a 5-day burst of prednisone, our typical management of an asthmatic exacerbation, which showed similar positive benefits in those recipients as compared to the dexamethasone. It was not a head-to-head trial, just using prednisone in place of dexamethasone in this trial. So that provides hope, I think, for our patients who already have or are showing evidence of reactive airway disease. They will benefit, I believe, from the prednisone challenge that we would use in any other virus-associated with wheezing illness. So those are the two major interventions right now. Yes, the debate still rages on other interventions. Certainly in parts of Central and South America, ivermectin has been achieving significance. I would propose that the data supporting that is similar to that supporting hydroxychloroquine, without perhaps the presidential support that medication had. So few options, but the ones we have are actually working. Again, kids seem to do well, and knock on wood, my experience with severely sick COVID patients in hospital has been good. They've recovered. Yes, some have been quite ill, some have required pressors, ventilators, but they have recovered.
Excellent. So as predicted, there's no shortage of questions. They're still rolling through. So we have plenty of material in the future for discussion, both on our website and podcast, and possibly another panel in the future. But I want to thank everybody for coming today, for taking the time out and to discuss this with us. We really, really appreciate it. But in closing, is there a resource that each of you could suggest that parents can go to if they wanted to get more information on how they can help the community and prepare their children for getting back into activities?
Well, I'll start with a note of caution against the social media-based education. I think we all shudder when we think of Dr. Google. And so I'm a big supporter of asking the person who has the information. So asking the pediatrician, even advancing those questions to infectious disease provider, to a bioepi person. I'm a huge supporter of face-to-face or phone-to-phone conversation.
Christine, Dr. Wilson?
Yeah, so I was just going to say, so the toolkit that actually we released from the AzAAP last week has a lot of great resources, even from the perspective of sports medicine. And so there are a lot of great links in there. It links to the AAP return to sport document that I mentioned. It links to the Healthy Children recommendations, as well as to the CDC return to sport guidance as well. And then the other thing, and I'm not sure if we actually included it in there, but we're happy to share it, and I have shared it with the AzAAP, and we can make that available to all of you as well, is the AIA return to sport document as well. And then that is a living document, so as we update it, I will also share that with the AzAAP to then update their resource that they have for you, or we'll just make the link to where it gets updated all the time. And then the additional thing, as I mentioned, the modifications to fall sports that we released, we'll also make that link available, guys, so that you guys can reference that with your patients, of making sure that just at their school they're doing the things that they should be doing. I just wanted to add really quickly, much like we talked about with a phased re-entry potentially to school might be the best approach. We have also recommended that, and we'll be recommending that most likely from the AIA standpoint in the next couple of weeks, because there are obviously sports that are naturally socially distanced in the fall, such as golf, which is easy to do, cross country, as well as swim and dive. And so we've discussed potentially having a phased reintroduction to sports so that we can get the kids active doing some, and they can get those benefits from physical activity. We might even have some athletes cross train and actually do a different sport for the fall this year, because there are some sports that obviously, as we mentioned, are going to be very challenging to get back to from contact sports, and as sports are doing well, and as the rate of community transmission is lowering, we might be able to introduce then badminton and volleyball, and then obviously progress into football, but that's why that date has been delayed. One of the challenges that we're trying to fight is that there are organizations, as we mentioned before, who are not regulated and do not have any guidance and do not have to adhere to any regulations, that have actually told parents flat out, if the AIA is going to be really strict about doing things and you're not going to have a football season, we'll make sure that you have a football season. And there are kids that have schedules for football already with club teams in the Valley to be playing this fall, and they've opened that up to high school athletes as well. And so we're trying to make it so that we can at least have kids in a safe environment that has some regulation and some guidance that is evidence-based, to try to help mitigate those risks that, obviously parents feel that they need to put their kids at to get them, the exposure they feel they need for scholarships and other things.
Thank you. Dr. Christ?
I would recommend knowing where your community is. We update the data every day on our website. If you go to azhealth.gov and click on the data dashboard, you can drill down by county to see county specific, but we will be adding county specific dashboards related to the benchmarks for school. But we also have a lot of different links to the CDC, to a lot of professional organizations and their guidance and recommendations on the website as well.
Thank you. Mark?
I would second what Dr. Elliott said about as you're making a decision for schooling, don't go to social media or your neighbors. Go directly to the school district website and even to the school. If you have questions about a school, the principal and the teachers are more than willing to talk to you right now, probably in a virtual environment, but go to the source, because you'll find that the schools and the districts want the same thing that you want: a successful, safe environment and an education that is challenging and provides your student with a happy, productive life. We all share that goal.
Well said, well said. So I want to thank all our panelists today. We really appreciate you spending this time with us and giving us your information. I also want to thank Dr. Mary Rimza and Lauren Valdiviazo for their behind-the-scenes contributions to this. And also, if you found this information informative and you want to have more information, I urge our members to go to the Arizona AAP Pediatric COVID Training Center, and that's at the AzAAP.org website. And also, you can send us questions at covid@azaap.org, and those questions we will address either in podcasts or in other forms on the website. So thank you, everybody. Stay healthy.
Thanks all.
Thank you.
Thank you.